My name is Adrian Beard from the EFMP Central Cell, and I will be your facilitator for today. Welcome, everyone, to the 13 March 2024 EFMP Connect. Today's conversation will be Autism Support for Department of the Air Force EFMP Families. Our speakers will be Ms. Tammy Hearn, Director, EFMP Central Cell Air Force Personnel Center, Dr. Christina Biena, DHA Medical Affairs ACD Clinical Lead, Dr. Justin Roberry, Director, Developmental and Behavioral Family Readiness Center, and Air Force SG Developmental and Behavioral Pediatrics Consultant, Dr. Veronica Batchelor, EFMP Central Cell Developmental Pediatrician, EAP Physician, and Ms. Erin Che, Special Education Specialist. Without further ado, Ms. Hearn, ma'am, over to you.
Thank you so much for joining us for this very important conversation. We look forward to presenting, but more importantly, we look forward to connecting personally with you in our breakout groups. Autism is the second leading reason for EFMP enrollment across the DAF. Certainly the growth in that enrollment reflects the need for this conversation, right? Ensuring that our families are taken care of, ensuring that as we reassign families, we are checking for that care at the gaining location. But what's interesting is the second leading reason for family member travel screening disapprovals to a gaining location is the unavailability of health care specialty services for our autism children. So what we look forward to today, again, three different perspectives. We have the Defense Health Agency. Dr. Biena is a great resource and leads this effort at the DHA level. Dr. Roberry from the Air Force SG office, and here in the Central Cell, Dr. Batchelor. They'll present some great information, which will hopefully spark your questions, and then we'll join breakout rooms and hear from you all. Without further ado, I'd like to introduce Dr. Biena from the Defense Health Agency. Ma'am, over to you.
I am, and I'll turn on my camera. Hopefully you all can see me. I can't see myself, so hopefully you're there. All right. Hi, everyone. My name is Chris Biena. I am a clinical psychologist, and I am here in the National Capital Region at the DHA headquarters in Falls Church, and I am the clinical lead for the Autism Care Demonstration. So I'm going to focus most of the presentation on the ACD, but I'll start with a little bit of background about TRICARE and covered services. So if we go to the next slide. I have only 3 slides. This slide here is going to be my main slide for talking points. But to start, TRICARE covers a wide range of medically necessary and appropriate services for the diagnosis of autism. Most commonly, these services include speech therapy, occupational therapy, physical therapy, sometimes medication management, which you'll hear a little bit about later from Dr. Batchelor. We also cover psychotherapy and maybe some nutrition services if medically necessary. Also, TRICARE covers under a separate authority the applied behavior analysis services. That's under the Autism Care Demonstration. It's under the demonstration authority as presently, ABA services doesn't meet the reliable evidence standard as defined in statute and regulation. It's a lot of legalese, but there is a distinction in what is covered under the TRICARE basic medical benefit and then under the Autism Care Demonstration. Having said that, ABA services authorized under the ACD are targeted towards the core symptoms of autism. So those are the social communication deficits and then the restrictive repetitive behavior deficits. Those services are generally provided in the home or clinic setting, and under certain circumstances could be authorized for the board certified behavior analyst to render in other pre-approved settings. Medical services non-medical or non-clinical services are outside of the scope of coverage for the Autism Care Demonstration. And I want to take a little bit about a moment to talk about what that means and how that looks nationwide, worldwide actually, but nationwide. There's There are 50 state mandates that cover certain plans to cover ABA under their authorities. Those vary widely. So these commercial plans, these employer plans, there are also Medicaid plans, but a wide range of services to include things like the scope of coverage, the cost of coverage, how much, how much by age, how much by dollar. So there's a lack of, I guess, industry standard about what is and is not covered, but wide ranging for sure. And I also want to point out that services can and should look different for each and every child over the course of time. So what a 2, 3, 4-year-old might have recommended for ABA and other services might look very different than what a tween or even a teenager or even a young adult who might need some services. Again, not just ABA, but all of the covered medical services under the benefit as well as ABA. I would encourage everybody to ensure they're consulting with their diagnosing and referring provider, whether it's the pediatrician or whether it's a psychologist, psychiatrist, neurologist. Any one of those folks can best help guide families on referrals and overall care. The next thing I want to talk about is the active provider placement. This is a feature specific to the autism care demonstration where the managed care support contractors, so I'll speak specifically about Health Net Federal Services and Humana Military, where the managed care support contractor is responsible for identifying an available provider. And what that means is that the contractors reach out to their providers in their network and say, hey, I've got a new beneficiary. Can you see them within the access to care standard of 28 days, yes or no? And if they can, then an authorization gets issued to that provider because they have confirmed that they can be seen. And in most instances, most locations, we're able to find available providers. There are definitely locations where the provider pool is slim, but in most locations, the contractors are able to find an available provider. Two things to point out. One, families always have a choice. So if the assigned provider is maybe not a preferred provider, or maybe if there's a preference on a location, whether, let's say you want home services, but you got assigned to a provider who can only offer clinic-based services, those types of preferences are certainly available, and I would encourage families to, choose what works best for your family, but also recognize that any of those preferences might risk access to care. So I encourage families to get connected right away with the assigned provider and then work out some of these other things as time goes on. Again, early intervention, early access is what we're looking for. I also want to point out the access to care challenges nationwide. We, again, generally can place families, but this isn't unique to TRICARE, that the commercial Medicaid plans, I can't speak to exactly what their challenges are, but I've seen them publish, like, for example, Massachusetts Medicaid just published a report, and they mention about challenges with provider access. And so anecdotally, I can say that it's, again, not unique to TRICARE, but we work really hard to get our families placed with an available provider. The next thing I want to talk about is outcome measures. I know lots of families have lots of questions about outcome measures. Generally, I want to point out that outcome measures are great tools for treating providers and the families, but for the treating providers to assist with monitoring progress or maybe lack of progress. And if we monitor outcomes over regular intervals, we can see those changes at specific time points and address where there's not. Maybe it's adding something new, taking something or revising something, taking out of the picture, into the picture, a new service, a different service. So that's part of the value of outcome measures. I do want to clarify that the parent stress measures are not clinical outcome measures for the impact of ABA, but rather measures that the family can address within the system, right? So Do I need referrals for other services? Maybe for myself, maybe for my child, other children in the family system. Maybe the treating providers are developing goals within their respective treatment plans to help the family system and support. Again, your treating providers should be having these conversations with you. And if they're not, please let me know, because while I can't address the specific provider, that's an education piece that I can have the contractors ensure that they're doing. The next thing I want to talk about is the National Academies of Science, Medicine, and Engineering. They were charged in the National Defense Authorization Act in FY22 to conduct an independent analysis of the department's autism care demonstration. There were some edits made in the fiscal year 2023 NDAA, and so that was executed last year. The report should be available fall of 25, but why I mention it here is that I encourage everybody and anybody to access that link that I have on this slide and share your experience, share your successes, your struggles. The Academy is accepting all kinds of feedback, written feedback, oral feedback, letters, emails, all kinds of stuff. So again, encourage everybody to share their experience. And then the last bullet on this slide is actually my segue into my next two slides. So if I can ask to advance the slides, that would be great. So there are a myriad of resources between the contractors and DHA, and so I want to showcase what those are. Each of the contractors, so again, HealthNet, Humana, and the TRICARE Overseas contractor, each have websites with information dedicated to the autism care demonstration. Both HealthNet and Humana also have what are called ACD parent toolkits, and these are resources that translate the policy into readable, digestible information for the families. So timelines, things to think about, milestones to remember, like timing of outcome measures, and maybe other eligibility requirements, things like that. We also have robust resources on the health.mil website. Health.mil is generally the provider-facing website, so it has things like questions and answers, previous briefings that we've conducted, recorded, and have audio and the corresponding slides. On the TRICARE.mil website that's the beneficiary, generally the beneficiary facing website. That has what's called an ACD fact sheet. There are other fact sheets like for ECHO, things like that. But this ACD fact sheet, again, is a very abbreviated version of kind of like the highlights of what's most important: getting a new diagnosis, who are the appropriate providers, by whom you could have a diagnosis, and then other timelines and important pieces. The last thing I have on here before my next slide is the DHA email address. This is it's from me and the autism team at DHA headquarters, where we field questions regarding program or policy questions or concerns. Maybe it's about specific pieces of the policy, or maybe it's about feedback about the managed care support contractors, or maybe it's a concern because you don't know how to reach somebody and we can help facilitate. I want the disclaimer there is that I and the rest of the team at the DHA don't have access to beneficiary information. So I don't have your treatment plans. I don't have your electronic health record. I don't have any of that. Any of those types of questions would go back to the contractor to help address. If I could go to the next slide, please. Again, this is information for HealthNet and Humana. Both contractors have dedicated phone numbers and specialty folks who are the autism care demonstration focused phone lines. These are great phone numbers, great resources, great links for everybody to have and share. And before I turn it over to the next presenter, my one ask for everybody on the call, whether you're a clinician, whether you're an EFMP a connected person through the Air Force or maybe a family member here, that anytime you hear struggling, the first phone call should be to their managed care support contractor who is dedicated to provide that support. We carved that out under the Autism Care Demonstration, and I definitely want to reinforce and say it as many times as I possibly can that services and supports are available, and please reach out anytime you have a question. And I believe the next presenter is Dr. Roberry.
Colonel Justin Roberry. I'm the director of the Developmental and Behavioral Family Readiness Centers, and excited to talk to you about this program. Next slide, please. So it's no secret that the Air Force often works in resource-constrained locations and does so on purpose, right? So there's a lot of advantages to that, strategically speaking, including airspace, stealth, and proximity to the mission. However, working within those resource-constrained locations can create medical difficulties for the military and its families, right? Oftentimes, there's not enough network medical resources, and oftentimes there's not enough patient volume to keep network medical resources in business, and so they tend to go away. This causes a significant impact in military operations, right? Increase in EFMP travel denials, or reassignments, as well as family medical TDYs. All of this has the greatest impact on senior personnel because those are the ones that typically have more family members within the EFMP program. And this has a high impact on readiness. On the other side, this also impacts the health of military families, delaying diagnoses, delaying care, and decreasing overall military resiliency. Next slide, please. To further complicate matters, there's a growing developmental and behavioral health need. For example, in the past 11 years, there's been a 47% increase in the annual military behavioral health clinic visits, and in the same amount of time, a 65% increase in the annual TRICARE behavioral health referrals. In addition, suicidality has gone up amongst especially our younger adolescent females, and the incidence of autism has quadrupled. Next slide, please. So what do we need, right? We need a way to provide care to multiple remote locations from a single resource location. We need a way to leverage video telehealth capabilities combined with in-person itinerant care, a way to focus on the highest impact medical specialty areas, and a way to build up local network resources. Next slide, please. So for these reasons, the DBFRC was created, right? So the DBFRC uses a healthcare delivery model that consists of video telehealth visits, supplemented with in-person visits where the providers actually go TDY to the spoke sites, right? To the remote bases and take care of patients there. And between those visits, there's video telehealth. They also set up developmental and behavioral extenders, which are primary care providers who are trained to go beyond their typical abilities to provide some of those additional services. It's provided in a hub and spoke model. And so that means that multiple bases can be covered by the same medical team from what's called the hub site. This makes specialty care available at smaller bases and also gives enough patient volume so that the specialists are fully utilized. The DBFRC staffing currently is just based off of the highest demand and impact for EFMP require developmental and behavioral pediatrics or child and adolescent psychiatry or child and adolescent psychology or autism therapy or a combination of the above. Next slide, please. So the DBFRC started as a program within the Pacific Air Forces, and I'm well aware that some of my PACAF friends are online, so shout out to them. So within PACAF, the idea was we needed to find a way to have this efficient and effective hub and spoke care for developmental and behavioral services for dependent minors, right? So a 4-person team, which consisted of a developmental and behavioral pediatrician, 2 child and adolescent psychiatrists, and 1 child and adolescent psychologist, were all inserted into PACAF to cover bases in Alaska and Guam and Japan and Korea. Next slide. And we've seen over time consistently positive results, right? Including a 50 to 60% decrease in EFMP travel denials for the DBFRC covered specialties, prevention in over 130 relocations and 400 medical TDYs and 6 hospitalizations average per year, a decreased wait time for autism evaluations by over 50% compared to the network, an average estimated savings of over $5 million annually on reassignment and medical TDY costs. And based on the strength of those findings, the program expansion started in 2021 to go from 1 hub to now 9 hubs. And those hubs are in various stages of manning. Next slide, please. Right, we have 6 hubs within the continental United States and 3 hubs outside of the continental United States, including Japan, Europe, and Alaska. Of those hubs, we cover about 70 remote locations. Next slide. So let's talk about what the DBFRC does and what the DBFRC doesn't do. So it does not duplicate services. So if your remote location happens to have a particular service, that service will not be provided by the DBFRC. It'll be provided by your local area. Second, DBFRC makes it possible for families that have someone with mild to moderate symptoms to be located at more remote locations, right? But mild to moderate is the key there. Patients with severe symptoms are not appropriate for this system because based on the severity of the symptoms alone, that patient needs to be at a hub site, at a site with a large amount of resources. So because it's not appropriate to provide that kind of care, that's not what we do. And also, when we're thinking of providing the most care possible to the most families, we find that we can provide significantly more care to patients with mild to moderate symptoms than those with severe symptoms, sometimes even 10 to 1. Next, DBFRC provides care for patients with new onset symptoms, which reduces EFMP reassignments. In fact, I would say of the patients that we've treated, most of them have been new onset symptoms, a little bit over 50%. DBFRC decreases wait times for high demand specialists. It maintains an in-person component to maintain standard of care for services that can only be delivered in that way. Now, there is a whole lot of capability to video telehealth, but there are some things that can only really be done well and up to standard of care in person. And so we're insistent that we maintain an in-person component. And last, I wanted to point out, DBFRC services for any particular area are dependent on the specialist staffing at the hub site, and not every hub site is staffed in the same way currently. Next slide. So back in 2019, when the DBFRC precursor started in PACAF, there were 4 providers and no support staff. Currently, we're up to 24 providers with 5 nurses, 2 technicians, and all of that within 9 hubs. All of our hubs do have a developmental and behavioral pediatrician. We're receiving 2 more developmental behavioral pediatricians this summer. 3 of our hubs have child and adolescent psychiatrists, with 2 more coming on board this summer. We also have 4 hubs with a child and adolescent psychologist, and 5 hubs that have at least 1 Play Project Autism consultant. So the Air Force Surgeon General plans to continue to push for manning so that all providers, all the 4 types listed above, are at every hub, and that there's also support staff. And then second would be to add dependent mental health providers to the hubs as well, as that is also a big need. Next slide. Okay, thank you so much for your time. I'd like to turn the time over to Dr. Belcher, who's going to talk about autism and services.
Hi, good afternoon, everybody. Thank you for having me this evening. First slide, please. I'm a developmental pediatrician with 23 years as active duty, Army, development of pediatrician, and serving families across continents. Spent 2 years in Germany, in Europe, and I TDY to at least 10 EDIS locations to provide service, and stationed in Hawaii for 3 years with TDYs to Korea. So I hope that I've reached out and with you in the past and hopefully continues to do so again. So next slide, please. What is autism? Next slide, please. So in 1943, an Austrian-American psychiatrist, physician, and social activist, Dr. Leo Kanner, published the first systematic description of early infantile autism. He described the child and 10 other children in a paper entitled Autistic Disturbances of Affective Contact. He concluded that this is a neurodevelopmental, biologically based disease that wherein children have come into the world with an innate inability to form the usual biologically provided contact with people. Since the late 1960s, however, the growth of autism discoveries have become exponential, mainly due to advances by discoveries in behavior intervention for young children with autism, and that created the impetus for earlier accurate diagnosis. So how is it diagnosed? The Diagnostic and Statistics Manual is a taxonomic and diagnostic tool published by the American Psychiatric Association that provides standardized criteria for diagnosis. It is described essentially through characterized behavioral and developmental features affecting social communication and interaction with others in a shared and reciprocal way, and presence of restrictive repetitive patterns of behavior, interests, and activities. It's a spectrum, so it could vary from very mild to very significant level of dysfunction. In some individuals, the severity could include affecting their day-to-day activities, as well as emotional control and self-regulation. And it can be associated with dysfunction, including eating difficulties, sleeping problems, anxiety, ADHD type behaviors, aggression, whether to themselves or others. Next slide, please. In the Department of the Air Force, there are over 4,000 families identified with a dependent with an autism diagnosis, bearing in mind that this is considered genetically based condition, and in some families there have more than one individual affected. In the US, there are greater than 5 million Americans affected. Worldwide, there's also a global prevalence increase. Dr. Roberry had mentioned the exponential rise in identified cases over the past years. In the last 10 years, it's doubled. So therefore, there is such an increased recognition and need. Next slide, please. What are those services that can be of benefit? Speech and language therapy intends to improve functional communication through verbal, nonverbal means, body language, pragmatic language, intelligibility of speech, engagement in reciprocal dialogue, and comprehension in order for an individual who's affected to respond to others in a linear way. Occupational therapy hopes to improve feeding difficulties, chewing difficulties, sensory intolerance, fine motor dexterity, visual motor coordination problems, self-care and adaptive skills such as dressing, toileting. How difficult is that? Even with children who are able to demonstrate that they have the skill, they may not be motivated to do so. So it could be very frustrating for others working with them. Physical therapy intends to improve motor abilities qualitatively and quantitatively. ABA therapy. ABA therapy uses behavior techniques to improve behavioral self-regulation, reaction, social responses through social skills training, Also works on adaptive skills, applied learning. Also works on sensory desensitization or tolerance, because those can be quite impairing, especially in very young children who are not able to communicate. Special ed services are available. Medically related services such as speech, OT, and PT are also available through the school system, and they work on social skills as well. And in some children, they may be eligible for adaptive PE. Applied learning is the goal, particularly for the older children, and reading comprehension can be a primary goal even early on. As far as medical, psychiatric, psychological needs, those disruptive behaviors we mentioned earlier can be very impairing, therefore may need to be additionally addressed through behavior coping techniques, emotional self-regulation techniques, and in some cases, medication may be needed in order to improve function. Medication, however, must only be done under appropriate medical care. Next slide, please. In the family member travel screening, mental and behavioral health issues and developmental and ABA related services are the primary reasons for dependent travel not approved. In some families, they may consider EFMP reassignment requests based on the lengthy ABA waitlist times. However, that's not recommended, because when you move from one area, guess what? When you go to the next, you then enter the bottom of the next list, which can also be very lengthy, and that's true nationwide. The Central Cell is using this data, however, in order to advocate for expanding specialty care services. For example, at Camden Air Force Base recently, bringing this attention to leadership has led to appreciable effects with more services rendered and available. Next slide, please. What are those challenges? There's a limitation on services in psychiatric, psychological, developmental, behavioral assessments, and appointments may take 12 to 18 months for a child to be seen. That is the national average. ABA therapy can vary depending on location and availability of credentialed service providers. Sometimes it depends on the availability of the child for them versus the availability of the provider for the child. These medically related services such as speech, etc., they can also be problematic, especially OCONUS, when a language barrier can be an issue. Average wait time, even within the US, can be 3 to 9 months. In children with more significant need, level 3, level 2, there could be additional difficulty in acquiring all the services that they need. If they, say, may have isolated speech therapy needs, hopefully they're at least able to get that, if not through the community, but through the school. However, if they have additional disruptive behaviors such as biting or hyperactivity, those may need to be addressed, and services for those may be difficult. The location. Dr. Roberry mentioned a remote location for Air Force families, and that could be difficult. Cost, TRICARE, acceptance as an insurance, and some ABA programs, they don't necessarily accept TRICARE as an insurance. Every time we transition in the questions regarding transition of services from one area to another and having difficulty getting on a wait list on the next area until you get there, it's a difficulty. Sometimes it's a turnover of the provider. You get into a service and then they have to leave for whatever reason that might be. Next slide, please. There are services available for diagnosing providers. In the Autism Care Demonstration, there are several authorized referring and diagnostic providers listed in the TRICARE website, and that includes not just developmental. So if the developmental pediatrician takes 12 months to be seen, perhaps a child neurologist might be available sooner. The clinical psychologists do have to be doctoral level, however, and board certified or board eligible. Next slide, please. For services that are publicly available, we have early intervention for 0 to 3, and the EDIS is available overseas as well as some areas in the US. For 3 and over, the Department of Education in the continental US or the DODEA overseas can be resources. So even if you don't have ABA, they do have services that are ABA-like or can address ABA goals, such as social skills training, in addition to, and I mentioned also about ABA is not all ABA therapists necessarily focus on academics, and therefore the environment at school can hopefully address academic and behavioral as well. Next slide, please. Other resources, again, mentioned for education services, psychological services such as parent-child interaction training, cognitive behavior training, especially for older children, may be of benefit. The book on the right is a publication that is ABA-based, and it lists and is written in layman terms, certain interventions such as for desirable behaviors like eating, toileting, versus undesirable behaviors like hyperactivity or biting. So I encourage everyone to at least consider that. Next slide, please. There are other resources, and many are available throughout the nation. The Organization of Autism Research is a program, however, that is a nonprofit ran by families who have military families who have dependents with autism. And so they share insight regarding strategies that may help facilitate your move and acquisition of services and transition. The one on the right, Operation Autism, is web-based, and you might explore and hopefully find that helpful. So I will conclude my presentation there and like to introduce Dr. Ms. Che, special ed specialist, for her part of the talk. Thank you.
Thanks, Dr. Bachelor. I'm Erin Che, Special Education Specialist at the Central Cell, and I want to speak to you real briefly about things to keep in mind as a child transitions into school or becomes of school age. Next, please. So starting with who gets school services. For those that are 3 years old or over, in order to receive those special education services at the school, that could be instructional support or related services such as OT, PT, a student must undergo a formal evaluation by the school team and be found eligible under one of the 13 disability categories, and one of them being autism. So remember that not every student who struggles in school qualifies for an IEP, and not everyone who has a medical diagnosis is eligible for an individualized education program or an IEP. So I'm going to focus mostly on children that are 3 and over, but the process of getting an early intervention developmental services for babies under 3 years old suspected of developmental delays are similar, and they will just need to be evaluated for an IFSP instead of an IEP, and that's the individualized family support plan. So I'm not quite sure if this is the right place to put it in, but I stuck it in here. If you already have been identified and you have an IEP from the state, and the placement for your child is outside of a regular public school, such as a special day school or a residential school, then we highly recommend that that particular information be disclosed in the DD 2792-1 during your FMTS or your family member travel screening process for both CONUS and OCONUS moves. This will help us to get your family to the place where they need to be, where that special school is. Next, please. Okay, another thing to keep in mind is the compulsory age for education in your state that you reside. For example, a child might be utilizing 30 to 40 hours, let's say, of ABA therapy as a toddler, but now is approaching that compulsory age. That's the age in which you have to go to school or be educated. For most states, that's 6 or 7 years old. But let's say you want to continue that 30 to 40 hours of ABA therapy. Well, what do? It's important to understand here that ABA therapy is a method of behavioral intervention and is not necessarily providing that educational or instructional service that the state Department of Education really requires. Thus, about 7 hours a day of ABA therapy can't really substitute for a school or instructional time when that child reaches that compulsory age. So you might be thinking, can I have my child's therapist provide those services at school? That's a question, a very familiar question to me. And our school districts, let's say, don't have the registered behavioral technicians, the RBTs, or the BCBAs at the schools. And more often than not, that is the case, that they don't have those qualified ABA therapists in the school system. But unfortunately, most school districts do not allow outside therapists to provide those services in the school or in the classroom setting. I've been told it's a liability issue with the schools. And to make it worse, the IDEA or IDEA, the Individuals with Disability Education Act, that's the federal law, does not require that a school use a specific methodology like the ABA in order to provide FAPE. And so what are you left with? What are your choices? Well, you can choose to homeschool if that's what you would like, and while receiving those ABA therapy hours outside of school. Just be aware that some states have regulations on how you can homeschool, what you need to submit in order to be approved to homeschool. So we'll keep that in mind. You can also decide to just enroll in school and work with your school IEP team for the most appropriate and hopefully ambitious education services, incorporating that ABA-like or ABA methodologies in that special class environment. And we'll talk a little bit more in a few more slides about the supporting agencies that could help you to get the most out of the IEP team at your school. Or the third option would be to do a hybrid of those two, part-time homeschool and part-time using the school services at your public institution. So next slide, please. Okay, so here we go. So this is a quick slide to just tell you that there's a link to that you could use to get the homeschool requirements that are all laid out by state. Next slide, please. And lastly, navigating that education system for your child, especially if your child has been recently found eligible for special education services, can be really challenging. And so I've listed some assistance available for you on and off base. And outside the gates, there are parent advisory centers. Those are funded by the Department of Education, at least one in each state. And you can find resources there, trainings there, individual advocacy, help with dispute resolutions with your school. And this is all free service to anybody who lives in that state. And then, of course, our Military One Source has a list of a whole bunch of other resources and links as well. That might be a good resource. And within the gates, you have the school liaisons, the family support coordinators. They can assist you with resources and facilitating that effective conversations with the school. And then our newest addition to our support family is the attorneys, who can now provide you with legal support, such as consultation, reviewing of your IEPs, and they can also, on special occasions, accompany you to an IEP meeting. So those are just a few of the items for your awareness as you advocate for your child's education needs. And I'm happy to field any questions for you. I think I'll be in room 2. So now back over to the M&O team and Ms. Hearn.
All right, thank you, briefers. So much information. And I know we started some conversations in the chat, but now we get the opportunity to meet you one-on-one. We look forward to hearing from you. Your feedback is so precious. It certainly allows us to advocate for you, but you can see through these briefers, the Department of the Air Force, the Department of Health, right? We truly are working to find those solutions to a nationwide issue, right? The growth and the need is tremendous, and so trying to catch up with the number of care providers is definitely challenging, but how can we support families as they PCS, as they transition? How do we help you understand the different challenges that are out there? So we've given you some of our challenges. Now we look forward to hearing from you, and we hope to answer those during the breakout session. So you'll see on the screen, we are ready for breakouts. And so Mr. Rubin, if you want to give us a few instructions, we'll be glad to move into those.